Welcome everybody to the sixth and final webinar hosted by the Justice Health Unit at the University of Melbourne on COVID-19 and detention. As is our norm in Australia, we want to start the presentations by an acknowledgement of the traditional custodians of the land that we're meeting on. For me, that's the Bunurong people of the Kulin Nation, and I'd like to pay my respects to their elders past, present and emerging, as well as to any Aboriginal and Torres Strait Islander people on the webinar tonight. Just to let people know, this webinar, as with the previous ones, is being recorded. For anybody who does need to leave at any point, you will find the webinar on our Justice Health Unit webpage in due course. You're welcome to access it there or share that with other people down the track if you wish. I'll just start by taking you through what the format of the webinar today is. Before that, though, just some quick acknowledgements. We have some funding support for this webinar series from the Centre for Health Equity at the University of Melbourne. We want to thank them for that, as well as the effort that's come from the Justice Health Unit, and in particular, Louise Sutherland, who's with us today, Claire Chiminello, who's done a lot of work in organising the webinars, Lindsay Pearce, who's also presenting today, and Claire Keane, who's a recent alumni of the unit. And also T Hin, who's provided fantastic technical support, as well as Lily May and Jessica Taylor from the University of Melbourne. So thank you to all of those people for helping us with this series. For those of you who didn't attend our previous webinars, this is, as I said, the sixth in a series of 6 webinars on COVID-19 and detention. And the overall aim of this series of webinars was to understand the policy and operational responses to COVID in prisons, youth detention centres and other custodial settings. And I'd figure out what things might have been missed from those responses and what impacts that might have had. And from that, the idea, I guess, was to start developing some recommendations for a more comprehensive and sustainable response to COVID-19 in custodial settings. And to that end, we've had 5 webinars so far. Starting in July of last year, the first was a global overview. The second focusing on decarceration as a response to COVID-19 in custodial settings. The third focusing on rights, accountability, information and standards. The fourth focusing on immigration detention as another setting where people are held in custody and are maybe at increased risk of COVID. The fifth focusing on Australasian issues, and this, the final webinar, last but certainly not least, is really thinking about a data-driven global response to COVID-19 in custodial settings and thinking about what the next steps might be in terms of policy, advocacy, funding and research. So Lindsay, thank you very much, Lindsay, has very helpfully gone through the first 5 webinars and had a look at some of the themes that have emerged from those. And so this is obviously a word cloud rather than any kind of comprehensive academic description of those. But some of the key words you can see there around collaboration between sectors and cross-sectoral responses, carceral system reform and decarceration, the notion that COVID-19 has been a pressure test of our custodial and custodial health systems, the importance of human rights and accountability, of reintegration for people transitioning from prison to the community in the era of COVID, the importance of the voices of people with lived experience. And down bottom left there, you can see one that we're going to focus on today, which is the importance of an evidence-based and data-driven response to COVID-19 in custodial settings. So in this webinar, the last one, these are the issues that we're hoping to explore. The first is what data are currently available on COVID-19 infection and responses, including obviously vaccination in custodial settings globally, what additional data are required for an effective and sustainable response, and what opportunities there might be for enhancing global data collection, particularly with respect to COVID-19, but also improving our capacity to generate evidence on the health of people in custodial settings more broadly as well. So we're thrilled to have a really fantastic lineup of speakers, real experts from around the world to speak with us today. So I don't want to take any more of their time than necessary. Very briefly to introduce our speakers. The first is Lindsay Pierce from our own unit, the Justice Health Unit at the University of Melbourne. The second, Dr. Felipe Alves da Costa from the WHO Health and Prisons Program coming from Lisbon. Tríona Lenihan from Penal Reform International from London, Dr. Elena Leclerc coming from ICRC, the Red Cross in Geneva, and last but not least, Peter Severin, former Commissioner for Corrective Services in New South Wales and Australia and current president of the International Corrections and Prisons Association. So we're very grateful to have these very busy, well-respected people giving us their time today. So with no further ado, I'll hand over to our first speaker, Lindsay Pearce.
Thanks, Stuart. Hi, everyone. Good morning, good evening, good night, wherever you are in the world. I'd just like to acknowledge that I'm speaking to you all today from the lands of the Wurundjeri people in the Kulin Nation. And I'd also like to pay my respects to their elders, past, present, and emerging. And I'd also like to acknowledge the fantastic work of all the colleagues that are listed on this page, just in their contributions. And this, just for a bit of context, this is a kind of a side project to kind of go alongside this this webinar series, and it's kind of timed really nicely. We've got a publication coming out. It's currently in press. So just to be forewarned, I'm not going to cover much about methods. If that's something that you're quite interested in, I'm happy to answer any questions on email, but stay tuned for that publication. You can go to the next slide, Stuart. Thank you. So as you're probably aware, following the announcement of the pandemic, there was a rapid influx of publications outlining recommendations for the prevention and control of COVID-19 in custodial settings. And this is at a time when governments and custodial authorities were really needing to act rapidly to prevent the introduction of COVID-19 into these settings, as well as limit its spread when it inevitably did, breach those walls. And this was quite challenging for a number of reasons that we've covered in other webinars. Really primarily that health and justice sectors often did kind of work in isolation from each other. So this was a huge challenge in that sense, and it really required a lot of coordination. There's a lot of movement between custodial settings and the community, so clearly a huge concern for public health. But also, and sometimes some of the less mentioned aspects of this is that people in custody are highly vulnerable to COVID-19 and severe complications because of their vulnerability in terms of communicable and non-communicable diseases, but also due to their mental health or high prevalence of mental health issues. So there's quite a few consequences in terms of introducing lockdown style measures and reducing restricting freedoms among people already deprived of liberty. So that's a bit of context. If you go to the next slide, Stuart. Thanks. So why conduct a review? And we kind of saw this as an opportunity to really make sense of all the information that was coming out in the least sophisticated kind of reason, just to put it all together. Really in all the documents that we identified in this review, no one document covered all the aspects that we identified to be really important. And some other reasons being just to identify key elements and principles of response. There's a lot to consider, and especially in areas where there might be resource deficiencies, to identify some of the key aspects, to identify what additional evidence we need. Obviously, at the time that these recommendations were made, we didn't really know anything about COVID-19. And they weren't made with a sense of how to implement them, just that we needed to do something. And finally, to provide a starting point to evaluate what was done versus what was actually recommended. And that's a key piece in terms of accountability that I think will be a key theme today. Next slide. So this is basically just to give a flavor of the documents that we found, of which there were very many, and we went through these systematically within our team. So in terms of WHO-defined region, they were primarily either not specific or international documents, or either from the Americas or Europe. And in terms of types of publications, you can get a sense of what types of documents were available. Primarily, what we found was general guidance statements and peer-reviewed. Oh, and just to note that this was in the time period leading up to June 30th, 2021. We really wanted to focus on that initial response and in terms of what was available. Next slide. So we systematically went through these documents. It was quite the task, but we identified 374 unique recommendations across 19 key domains, which can kind of be thought of as key elements of response. So we kind of look at these 19 areas as a bit of a framework in terms of the key aspects and what we should be considering. And I just highlighted two of those there that I think are quite pertinent for today's discussion, being recommendations around surveillance and information sharing, as well as learning systems and evaluative frameworks. Next slide, please. So this is just a very brief summary. We have pages and pages and pages of things that we found. Clearly a very important area, but just to highlight, there are many recommendations for regional and national surveillance, and that included some basic epidemiological information such as testing rates, case numbers, infectivity, treatment provided, and deaths, just very basic building block information in order to assess, what's really happening and get a sense of kind of the spread and the scope of the problem, as well as consequential outcomes such as incidents of self-harm, incidents of unrest as a result of some of these measures that were recommended in order to prevent the spread of COVID-19. There was also plenty of recommendations for information sharing with local health authorities and correctional facilities. That's kind of in the terms of day-to-day and managing cases, and regional and international stakeholders to, really promote knowledge sharing and improving the response over time. Evaluation was another area that was highly touched upon in these documents in terms of effectiveness on reducing COVID-19 infection, as well as their impacts on the health and human rights of people in custody. And finally, and this is something Stuart mentioned, and I think it's come up in every webinar, is that we really need to be involving people in custody and staff to supplement our other data sources, as they're the people that are really in it, and they're the experts in their experience, and we need to be listening to what they have to say about their experiences, especially when it comes to human rights. Next slide. So I think a key thing that we kind of concluded from this is that guidance is certainly necessary to drive an effective and sustainable COVID-19 response, but it really is not sufficient. And this document from Amnesty International might be familiar to some of you. Essentially, they gathered data from 69 countries, basically what data was available, and they really found that there wasn't a lot available, but they basically concluded that the response was woefully inadequate when you look at the scale of the problem and some of the consequences of it. And specifically in relation to this webinar, they identified that very few countries had any sort of publicly available data. As I mentioned, that kind of basic data on the epidemiology, and even fewer disaggregated this by subpopulations in custody. And this is just really critical in order to have good data on and protect some subpopulations of concern, particularly people with mental health issues or disability or Indigenous people. And we really shouldn't be relying on assumptions. And I think this quote that's just up there, I won't read it, but I think it does a really good job at kind of just putting out there the importance of having like a steady stream of data to help identify, the decisions we should be making and having a evidence-informed approach moving forward, which is really critical, particularly in terms of accountability. Next slide. So this is my final slide. I'm not going to go through line by line because I basically covered a lot of it, but I think just one of the things that I'd really like to summarize is that the gap between the information that we need and what is currently available is quite wide. And it's going to take a lot of collective action to get us where we need to go, and it's going to take some time. I'm hopeful that we will get there, and hopefully other panelists have some thoughts on that. And I hope that this webinar can kind of get us going in that direction, but it's really critical in terms of fine-tuning the response, and while also minimizing harm on people in custody and staff, particularly in relation to human rights and mental health, by holding custodial authorities accountable to the health of all people in custody, and as well as developing custodial systems that are just better placed to respond to other novel health issues in the future that may arise. And as we know, there probably and will be some. So we really need to address some of those things, and data is one of the surefire ways to do that. So that's all I have. I'm looking forward to hearing the other speakers. Thank you.
Thanks very much, Lindsay. That's a terrific introduction and covering a huge amount of information in a brief amount of time. Look, I neglected to say for folks joining us tonight that what we're trying to do is leave all the discussion till the end. So for people who do have questions or comments for Lindsay or any of the other speakers, please enter them into the Q&A. And Louise, who's on the call with us tonight, will be facilitating a discussion and communicating those comments and questions to the speakers at the end. So please dive in, comment, question, make a contribution to this discussion. So without any further ado, our second speaker, Dr. Felipe Alves Costa from WHO. Filipa, over to you.
Thank you, Stuart, for the first of all, for inviting us to be part of this webinar on this important issue. I would like to, in fact, follow up on what Lindsay just mentioned and talk a little bit about how WHO has been contributing to fill in the information gap about prison health. So we are in alignment totally that there is lot of information missing. It's like a hole in the system. So the first thing we did, can I have the next slide, please? Was to develop a database in 2016, and this was called the HIPEDS database. So it's Health in Prisons European Database, which includes information that's gathered from member states. So it's not exhaustive, but in the first wave of this database, we collected information from 39 member states, and includes, of course, information on the health status of people living in this country, but also basic information on the population that's living deprived of liberty. So it does have also some information on health outcomes and risk factors. But what I would like to highlight above all is this fact sheet that you can see on the right-hand side, which shows you some of the major gaps that we have in health information. So although we are asking member states to report on this issues, they are not able to do so. So for example, only 2% of member states have data that allows us to understand how the proportion of people in detention that are overweight. And you can see that it goes a bit better if you scroll down, but still only 21% of member states are able to report on HIV or hepatitis C. Next slide. So we felt that it would be relevant, and because this is a database that builds on information that's collected periodically, we are now on currently collecting data again, this time with a few more member states. So we have 42 member states that are sending their data, but we felt it would be important to develop a framework that would standardize data collection. And since 2020, we have been working on this development of the WHO Prison Health Framework. And this will be officially launched in next week's regional committee, where we have for the first time a side event on prison health. So for the development of this framework, we have identified 5 priorities, which you can see on the slide. So strengthen prison health information system to enhance surveillance and response capacity, monitor health service provision in prison, track performance, obtain valid and reliable measures on the health status of people living in prison, and finally conduct intersectoral work for better performance and outcomes. Next slide. So to come to this framework, what we have done is we looked at the various frameworks that exist, and there are a lot of them that exist to monitor and measure healthcare delivery in a standardized way. And these have been proposed not only by WHO, but also by other entities. However, most of these frameworks are not specific for the detention context. And so what we have concluded is that they fail to capture the complexity of the healthcare delivery in these settings. So we used as a starting point, the WHO framework, which you can see on the slide. And the health system framework is composed of various domains, which you can see here. but some of them were then renamed or removed so that they would represent better the prison health systems. This framework was then evaluated in terms of relevance for the prison health context, and this was achieved by consulting a wide panel of experts, both internal and external stakeholders, to make sure that the framework would accurately reflect the core aspects of health systems in prisons. Next slide. So you can see here a glimpse of this framework, and you can see that it is now composed of two main building blocks. So the first one is on the left, where you can see the inputs, so the various levels of prison healthcare. Then the second block captures the provision, so the delivery aspects of prison healthcare, that would be the outputs. And then these building blocks are then modified by two influencing factors, so that's the prison environment and the health behaviors. And this will then ultimately lead to the impacts, which is the building block you see down. So that's the health outcomes block. So we also have the circles on the sides, which represent the two cross-cutting principles that by definition are, of course, related to these building blocks and influencing factors. And these are adherence to international standards for human rights and good prison health, and reducing health inequalities and addressing the needs of special populations. So this framework is, of course, an important step, but several other activities we have been developing to further strengthen the capacity of countries to collect and report health-related data for prisons. So one important activity that we developed in 2020 with, of course, a great contribution from Professor Stuart was the development of a minimum data set. And this is specific to COVID-19. So where the previous one, HIPAD, relates to the general aspects of healthcare, and here we are mostly concerned about COVID-19 related data. So this data set contains a reduced number of variables, and this enables the extraction of important indicators. And this is what you see on the slide is the protocol where we describe in more detail all the variables that are collected through this system. And it indicates why we think these indicators are important. So I'll just give you a few examples. So what we do with it is to have the aggregate standardized case of COVID-19, of course, the deaths, and then most recently on the update we had of this data set, we have also included data on testing in place and vaccination coverage. So on the right-hand side, you can see an example of data we have extracted recently from this database. Of course, the data still has lots of limitations. So namely, as you can see by the number of countries, it's not exhaustive. So this is a voluntary system where countries can report, but they are not obliged to do so. And even those that report, they do not necessarily report all variables. Anyhow, what you can see here in terms of vaccination coverage is that there is wide variability, and currently it ranges from 1% to nearly 90%, depending on the member state. So this is one starting point, and just showing you that we have to do much more to increase the information, to close the information gap that we have in prison health systems. Next slide. And it's just my closing slide to thank you, and I'll be looking forward to receive some questions.
Thanks very much, Filipa. That's a terrific presentation, and it's exciting to see WHO continuing to lead the way with the collation of data on prison health. As you say, there are gaps in there, but it is, as far as I'm aware, the only effort to collate data at a regional level on prison health. So it's exciting to see that. Thank you for sharing it. Our third speaker today is Tríona Lenihan from Penal Reform International. Trina, over to you.
Thanks, Stuart. Yes, for anyone who isn't familiar with PRI, I'll just briefly say we're an independent NGO working globally for fair and effective criminal justice systems. And we do that through practical human rights-based programs across various regions and also our policy program. For the past 7 years, PRI has been monitoring a whole range of issues affecting prisons globally as part of our Global Prison Trends program with the Thailand Institute of Justice. And we've been publishing an annual report, which some of you may be familiar with. And I can definitely say that every year without fail, the availability of data on prisons has been an issue across a whole range of areas. And this goes from very basic information, like the number of people in prison, the levels of capacity of prisons and staff numbers. So even this sort of information is not always captured or transparently available. And this is really a particular issue in low income countries and fragile and conflict affected settings, where a lack of resources is really a serious challenge. And in some places, we see that, prison records are still mostly manual and they can differ across prisons. So this causes a real barrier in sort of national data availability and coherence. So the digital divide is a major factor in these settings, and the impact of that is increasing hugely during the pandemic. Other factors we've seen impacting the collection and availability of data are some very practical difficulties or cumbersome procedures, and also decentralized systems. So where different aspects of prison management are covered by different arms of governments or agencies. And this means that data is scattered across different ministries and services. We have the classic case of the Philippines, for example, where prisons fall under the Department of Justice, but then pretrial detention facilities are under the Department of the Interior and local government. Similar situation in the US, where also maybe political priorities might have been an issue more recently, and the bureau that collects and analyzes the national prison data being quite underfunded and understaffed and causing delays in publication. In some countries then, some of the barriers are quite specific to the country. Cases like France, where legislation really limits data collection on ethnicity and religion. And this, of course, also applies to data on prisons. And some countries exclude, for example, LGBTQ people from prison population data and other minority and marginalized groups. So these are some of the challenges in accessing any data on prisons generally. And then when the pandemic hit, we were reminded immediately just how important it is to have data that is current, accurate, and disaggregated by age, sex, ethnicity, and other factors, because this really allowed specific cohorts of the prison population to be identified for either release or additional preventive measures to protect them from infection. So I don't want to be biased towards my home country, but in Ireland, because accurate and disaggregated data was available, authorities were able to respond quite quickly to include at-risk groups in emergency release measures. And I think they managed to release about 10% of the prison population. And for those who weren't eligible for release, they could be included in changes to prison regimes. Some cohort of the prison population ended up what they called cocooning, so just sort of more extreme isolation. Which would, of course, over time have its own impacts, but in terms of infection prevention, it was quite effective. When it comes to health data in prisons, then during the pandemic, we've seen a number of key barriers in how this has been collected, reported, and used to inform the pandemic response. The first is around insufficient testing for COVID-19 in prisons. And that's both for people with symptoms and those that are asymptomatic. There's more detailed information on this in the Global Prison Trends report and some of our other briefings, but again, it's largely down to a lack of resources or places of detention being a low priority for testing programs. But apart from limitations around testing, transparency has really been a key issue on testing and infection and death rates, and that's been generally poor globally, with regional variations, of course. There are only a few countries that regularly publish updated data on testing in their prisons. Places like the US, South Africa, and Canada. Canada actually reports data for each individual institution around testing and results. And in some places, there's been just a total lack of information released by prison authorities or official authorities, as Lindsay mentioned as well earlier. The only global figures we have for infection and deaths in prisons from COVID-19 have been collected by Justice Project Pakistan, and that's from official sources where they are available, but largely from monitoring news reports. And even at that, still there are 70 to 80 countries with no figures at all. So their figures now show well over 500,000 confirmed cases of COVID-19 among prison populations in 122 countries globally, and over 4,000 deaths of people detained in 47 countries. But again, these are, likely to be hugely underestimated given all the limitations in access to information. In some places, this lack of official information also applies to what protocols or measures have been adopted and to prison releases. So a lot of the figures we have for the number of people released from prison in response to COVID-19 are actually based on the announcements earlier in the pandemic of how many were expected to be released when the schemes were set up. But information around implementation is much harder to find in some places. There was some research done by DLA Piper, which looked at 53 jurisdictions and found that of those, about 3/4 of governments failed to publish any official data on the number of people released from prison in response to COVID-19. And we're now seeing the same issue around vaccination against COVID-19 in prisons. Over the past few months, PRI, together with Harm Reduction International and Justice Project Pakistan, have been conducting a sort of global scan to see how prison populations and staff have been included and prioritized in national vaccination plans, and also progress on actual rollout. So the analysis around that is ongoing, and we'll publish the report next month. But there's been a real challenge, again, around transparency. First, in even publishing the national vaccination plan publicly in some places, but especially official data on vaccination of prison populations. And as Lindsay mentioned as well, disaggregated data on this is almost impossible to obtain in the vast majority of countries. When it comes to prison staff, then accurate information is also usually not available. In some countries, prison staff are considered frontline workers and a priority group for vaccinations. And in that case, some data may be available on the priority group as a whole. So that would include other essential workers as well that are in that group, but usually not specifically on prison staff. In most countries, though, prison staff are considered for vaccination as part of the general population. So they're included in their priority group in the community according to age and health. And this means then that no data is collected or available on vaccination of prison staff. So more detail on all of this will be set out in the report next month with figures and some case studies. So I look forward to sharing that with you. The final point I'll make, because I know I've gone over time, is around the impact of pandemic response measures on the prison population. So all of the visitation bans, restrictions on movement within prisons, and impact on programs and services. Some data is emerging already, showing an impact on mental health in some prison systems, but this is an area we'd like to see a lot more attention on in the short and longer term to assess the impact and the sort of ongoing long-term impact of measures and what can be done to effectively address that, both for people affected now and also to safeguard against similar outcomes in the future. So I'll leave it there for now and look forward to some discussion later. Thanks.
Thanks very much, Trina. You've covered a lot of ground there and really made the case for transparency of data and the importance of that. There are many, many good points you've made there, and I'll just remind the audience again that if you do have comments or questions, please put them in the Q&A and we'll try to get to them in the discussion at the end of this. So once again, thanks very much, Trina, for a fantastic presentation. I'll move on now to our third speaker, Dr. Elena Leclerc from the International Committee of the Red Cross. Elena, over to you.
Thank you, Stuart. Thank you for the introduction, and good day to all. And I'm really very grateful to have been given the opportunity to speak today on behalf of the ICRC. And it's already the third time that we join this series of webinars. So thank you very much. And as just before I start the presentation, I think you already know that the ICRC, we are visiting places of detention in some 100 countries around the world. So in different regions, we have 5 geographical regions in the ICRC. So Africa, Americas, Asia, and in the Pacific, Eurasia, and Near and Middle East. So we are visiting places of detention in these 5 regions, and we have health projects and activities in some 60 of them. So I will be sharing the observation and experience, which is driven from our experience in those 60 countries with you. All right. So I would like to start with these 2 key messages. And actually, for the almost 2 years, we are managing a COVID-19 crisis. And as it was said already on many different occasions, this crisis could be also seen and used as an opportunity and hope to reach the most vulnerable people, as in general in the community, but also among the prisoner detained populations, and for what we call for making the invisible visible. So we also think that it's a good momentum for strengthening healthcare access for all health conditions, and not only for COVID-19 disease, and improve health outcomes for people in the prisons. However, and I think I don't say anything new here, this goal will be very difficult to achieve if we don't have a reliable and health information and data available. So I was asked to reflect on the importance of health management information systems, and I think it seems obvious and acknowledged by everyone concerned, be it the detaining authorities, the health ministries, or other health stakeholders involved in prison health, that health data is important. For understanding the needs, for prioritization, planning, development of general responses or response during the public health emergencies. So, but however, having accurate, timely, standardized prison health data, which is also harmonized and integrated in the national health information systems, remains to different extent, but the main concern and challenge in the majority of countries that we are visiting as ICRC. Next slide, please. So we are looking here at different dimensions, 3 dimensions of health information systems. They are in front of you: health determinants, health status, health system performance. And maybe the most, probably the more easily available and accessible data will be on the health status of detainees, morbidity and mortality, and not without challenge, again, not always very accurate, but it's the mostly available data. So I would like to share with you this graph, which is by itself quite an interesting one, and illustrating the trends and the morbidity trends in the top 10 in the places of detention that we visited as ICRC. So you can see that the non-communicable diseases are taking really the first places among other conditions. And this is aggregated data for the world, the countries that we visit. But if we disaggregate and aggregate by different regions, we will observe exactly the same trends. 2021, from the January until now, shows exactly the same picture. What is interesting here is that the first place was taken by the respiratory tract infection, acute, and we see the increased number of these conditions in the 2020, 2021. It could be explained by the maybe undiagnosed COVID cases, which were for different reasons, lack of testing and diagnostic capacities, and other elements that they were underdiagnosed and then reported as just respiratory tract infections. So here, I just took the same slide from the first webinar that we did 1 year ago in July, and 1 year ago we said that to respond to COVID-19 and beyond that, we need to strengthen monitoring and evaluation of COVID responses. There were, of course, a lot of efforts and progress made in this regard. But as previous presenters highlighted, my colleagues, there is still quite a lot to do and to enhance that this monitoring and evaluation for COVID and in general. Okay, so this is just an example of indicators that we are collecting and in the places of detention. I didn't put figures. We have numbers in, but I didn't share it with you because, once again, as I said, this total number of new cases, aggregated cumulative number of cases may be not that representative because there were a lot of cases underdiagnosed and not reported in the system. So it's so that's why I didn't put numbers. But these are some of the indicators that we are looking at, and that as ICRC we are supporting the national prison authorities and health authorities to collect this information on, the situation, the COVID-19 situation, but also on the response and the vaccination, the performance of the COVID-19 vaccination program. Right, so it's almost the last one, and so what we can say, there are quite a lot of old and new challenges, right? So it's the generally known, the lack of standards and guidelines for data collection and reporting procedures. There are still an insufficient number of qualified staff to collect and analyze the health information, and we have globally a lack of regulation, which mandating prisons to report the indicators and integrate them into the national health systems. As it was said before, there are also let's say the challenges and lack of maybe transparencies and so forth. But I mean, it's for us, we believe, and it's not only us as ICRC, it's that the integration of prison health data into the national health information system is really crucial. Maybe this was the last slide. So it's just to conclude that we, as ICRC, we really we do a lot in terms of strengthening health information system and use different platforms, internal, international, to improve the data collection and health information systems in the country. So here are just a few examples. One of them is the last conference, Asian and Pacific Conference on prison health, 2019, but it was the subject and the theme of the previous Asian and Pacific conference. We had 3 in total before COVID. So the recommendations delivered by this conference were to support the development and establishment of minimum data set for prison health for Asian Pacific region, similar to the experience that was done by on the lead of the WHO Europe for the European region. So this was the ambition and the willingness to have similar minimum data set for the Asian Pacific, establish an integrated health information system between detention settings and communities. So these commitments are extremely valid today, even though we couldn't, progress as fast as it was we wished to because of, again, COVID, but voila. And all other regional events, be it in the Near and Middle East, Near and Middle East region, or the upcoming conference that I will not talk a lot, but this is the event which is planned for next year in 2022. So the theme and the topics around health data evidence will be there, and it will be a great, again, opportunity to exchange on the information, the data, the research on this platform. So that's my last slide. I hope I was on time. Thank you, Stuart.
Thank you very much, Elena, and apologies for the technical difficulties there. We had a PowerPoint crash, so
no problem.
You carried on seamlessly, so thank you very much. Look, you've again touched on many important points there that I'm looking forward to getting into a bit more in the discussion. A reminder again for the audience to type your questions into the Q&A. I see a few questions appearing already. Please keep them coming. We're all very keen to hear your thoughts too. Moving on then to our final speaker, Peter Severin, from now President of the International Corrections and Prison Association. Peter, you have no slides, so I'll stop screen sharing at this point and over to you.
Thank you very much, Stuart. And I hope my microphone is not playing up as it was a bit earlier. If it does, I apologize for that. I also like to acknowledge the traditional owners of the land where I am in Sydney, Australia, and pay my respects to elders past and present. And I particularly would like to acknowledge the speakers here this evening in my time zone, morning, and wherever the others are. What a rich and informative dialogue and presentation already. I think it's fair to say that COVID has been impacting on the prison system as nothing has ever impacted before on a global scale. And what we've just come to realize now is that really what we're doing is managing the challenges of a very much changing reality. So anybody who thinks that life will be the same in the correctional setting as it was pre-COVID, I think needs to think again. And I think that sort of sets the base also for opportunity as much as it presents challenges. And I'll talk a little bit more about that. As we've heard, we had around about 500,000 prisoners, and that's just the recorded data. Elena was alluding to the fact that a lot of data wasn't recorded, had been infected with COVID-19 up to about June of 2021, and around 4,000, as Trina pointed out, prisoners and staff have recorded to have died from COVID. And that in itself is a very sobering outcome and a very sobering reality. But what I can say also is a lot of good work was done in the corrections environment when COVID first started to become a real challenge. And what I was particularly pleased with is that the work was done globally. So while there were obviously pockets of excellence and pockets of activity that were particularly remarkable, and I mean, these webinars is just one example of those, we also were able to actually cover a lot of ground for people in poorer countries, in developing countries, particularly in Africa, Latin America, who not only dealt with COVID as a reality, but also in the context of largely overcrowded prisons, systems that were challenged at the best of times and had to now deal with this situation in sometimes quite controversial political circumstances as well. But at the same time, and I speak from an ICPA's perspective, we coordinated a task force that very quickly brought practitioners together to share resources, share knowledge, share information, and start what we are really talking about here today, looking at how can we better share information in a more robust data-based process and approach. And it became very clear very quickly that there was a total lack of data and particularly data linkage. And I'll point out the most obvious issue that certainly we've come across. And it's not about people's unwillingness to share. It's because some data is just simply not collected, as we've heard before. But the real reality is that health data and corrections data is not automatically correlated. It is not automatically, even in the most developed countries. Now, it is almost impossible to get a situation where you actually combine your health data and your corrections data unless you actually commission quite extensive research projects. It's not built into the system. And I think that is one of the sobering observations that were made. And it's done because obviously health data in many ways has the privilege of being very much protected data, corrections data, a little less so. And then now people who are not health professionals are not able to actually interpret data, so they shouldn't actually see it. So the whole range of artificial, real, and other mechanisms that just simply stopped data from being combined and being meaningful in that context. And I have to say, though, that I've observed a real trend of people saying we need to overcome this. Now, where it makes sense to share, where it makes sense to involve data to inform policy and decision-making, we need to get much better at that, and we actually need to be a lot more open in sharing. I'm not suggesting that we're there yet, and I'm not suggesting that will not be a challenge that will be ongoing, but it is at least a start, and it is a start, like many things, that was triggered by the pandemic. So systems are starting to find better ways of integrating health data and custodial services, and that's heartening. But on the other hand, when we look at the challenges that we have at the moment, the problem that we do have disjointed data sets and also disjointed sets that inform better decision making, is that the prison system is not a homogeneous system. You've got a very busy front end. People come in, come out, go out. If they're infected, they come in infected. They don't necessarily get infected while they're in prison. They might have had a history of being tested. That is very difficult to establish. Vaccination adds a whole new dimension to it, and we heard a little bit about that today, during this presentation. At times we have no idea who has been vaccinated or not because it's self-information, self-reported information. So prisoners that come into the system, nobody actually has a record to say you have been vaccinated that is easily accessible. It's somewhere, but it's not necessarily part of a prison health database. Staff can go and get vaccinated in the community. They can get vaccinated in some systems in the prisons. And again, that muddies the waters a bit. So the other dimensions like identifying vulnerable groups, identifying how we best differentiate vulnerable groups from others, and how we manage those that are at most at risk of being infected with COVID-19 are just a number of the issues that systems are starting to actually come to terms with in a much more integrated way than before. So the opportunities that are currently being explored and continue to be explored in the practical sense is testing. It is the vaccination approach. It's the isolation and quarantine arrangements to take away from this notion that everybody just has to be locked away. There are much more differentiated opportunities to deal with the isolation requirements. And it is most importantly communication across systems, across the different services, be it the prison operations and or health and or both. Further areas to be explored involves modelling, a much more integrated approach to modelling in order to prevent. So modeling, if we do certain things, then we can actually stem the infection of the virus within a particular correction setting. It looks at as I already mentioned, better linking of prison and population health systems and data. It looks at education. I mean, people need to actually be on the same page in order to understand what it is that they can actually do, achieve, and how they can improve outcomes. And fundamentally, it's underpinned by a continued data collection and analysis and better data integration between the various parts of the system. And I have to say, unfortunately, it is also preparing us for the next pandemic. Now, is it the Delta variant or is it another pandemic? And whatever we do now is an investment into the future prevention of the same chaos that has been with us as a result of COVID-19 when it was landing on us. Briefly on ICPA, International Corrections and Prisons Association, we facilitated global dialogue. We do that obviously much in partnership with colleagues from the UN and ICRC and others. We continue to be very open to collaborate, to facilitate. We will have a new platform coming on stream, if not later this year, then earlier next year, and which will be a global platform which has got enormous capabilities and capacity to actually capture data. And we hope, and we don't do this for any other reason than to share amongst corrections professionals. So there are no commercial interests or anything else behind this. And of course, we're happy to be contacted by any of your organizations and happy to share and most importantly, to point people in directions of others who have already had the experience and may be able to share their knowledge, their pitfalls, their experiences, and their learnings. Thank you.
Thanks very much, Peter. Again, you've covered a great deal there. And I saw everybody nodding vigorously when you were talking about integration of health and correctional systems and data. It sounds like that's a fairly central theme that's been running through the presentations today. Look, I'll hand over now to Louise Sutherland, who will facilitate some discussion around this. And Louise, I think there's been a few questions in the Q&A, and you may have a few others that you wanted to fire at our panelists. So over to you.
Great, thanks, Stuart, and thanks to everyone. We've got about 20 minutes, so I'll get as many questions in as I can, but please feel free to keep adding more to the chat. We've got a couple in there. I guess one thing that I noticed throughout this, the panelist discussion was you were all very clear about some of the big barriers and the limitations and the challenges, but I thought it might be nice to start with a question about while it's really clear what, say, the detention health sector can maybe take and learn from the general health surveillance area, what are the strengths or the expertise points that maybe can be taken from the area of custodial health and could be taken into the general health surveillance area? Because there's a lot of complexity there. You've talked about all of the challenges that are being sort of confronted. Are there strengths there or things that we can learn from this custodial health space that would benefit the general health surveillance area in a COVID era? Elena, I can see you nodding, so I might direct that one firstly to you in case you've got some insights for us, some inspiration for us.
No, I just found it's an excellent question, and it's true. We could, both. The two systems, health information system, are interconnected, and there are elements that could be probably integrated from the penitentiary to the general national health systems. I don't know what could be an additional indicators to look at, but I probably let's say the penitentiary systems, there are some areas like looking at the health determinants, general health determinants, physical and social, that probably are not as closely
very basic. I mean, prisons are microcosms in many ways, and they're highly controlled. And obviously, those controls you can't simply translate into the community. But just learnings from access. I mean, all the things we've heard about hygiene and cleaning and mask wearing and so on. But also how to actually deal with situations where people have to isolate and control that in a way that is not dehumanizing, that is actually mindful of mental health considerations. I think there's quite a number of examples that I certainly, when in our case here in Australia, I can say that now some of the things that we prepared in the prisons have actually moved on into big apartment blocks that all have to literally lock down in Victoria and now in Sydney, and just to keep people's mental health engaged, healthy, and give them things to do. Were direct learnings of things that we trialed in prisons, and we found they were actually working. And as simple as little games, board games, other things that you can easily make people use. So I'm just using that as an example. So there are, I think, clearly in a very micro sense, some real opportunities. In a macro context, I think we're all so well covered now by all the wisdom we're getting from our epidemiologists and everybody else that deals with matters, that I'd like to think the prisons can learn as much as everybody else.
And just in terms of that, the question about data and how the sort of taking account of complexity in data collection and collation. Filipa or Trina or Lindsay, do you have any comments about, are there things that you've seen about those issues from the custodial side that should be taken on board in a broader health surveillance context?
I'll just perhaps echo a bit of what Peter just said. In terms of being a closed environment, in a way, it is relatively easier to collect the data because it's a closed environment, kind of. But however, the level of digitalization is not equal. So in certain countries, this could be an enormous advantage of the prison context, the fact that it's closed. But in other countries, yes, it is still an advantage, but with room for improvement in terms of digitalization.
I think there could be potential maybe where a lot of quality information is collected at admission stage, and if that can then be linked, to any health data accumulated over time while people are in detention. But I don't know how much those always link up within the system. I guess in terms of this closed institution as well, maybe there's more scope for observation and in terms of, collecting sort of health-related information through observation. But yeah, beyond that and what's already been said, I'm not sure.
Unless, Lindsay, was there anything you want to add to that?
Not particularly. I just think obviously there's a lot of challenges with data in the space, and perhaps this is just me coming from a research perspective, but it feels like attacking from all angles is the best way to do that in terms of getting different types of information. And just in relation to one of the questions that Robin posed in the chat in terms of mental health, there's been some early qualitative work of people in custody and their experiences of isolation, and just things that can be done, practical things that can be done to help protect their mental health in those experiences. So I think that kind of information is also very helpful especially when used in conjunction with data linkage or just regular data collection in these settings.
Thanks. And thanks for linking to that question from Robin. Thanks for your question, Robin. It's about the integration and inclusion of mental health in data in the response by health authorities and researchers. I might direct this first to Filipa, because it also connects in with another question from Amadou Akel relating to the HIPED survey. The question is, considering the variation between regions in the world, do you have any plans to extend the HIPED database to other regions? And would this be publicly available data for researchers and public health specialists? I'll let you answer that one first, and then talk about the mental health, the mental health inclusion in the data. Thanks.
Okay, so I'll start with the second part of the question. So HIPED is an open database already, and it's really available to anyone who wants to explore the data. I've entered the link in the question, the Q&A, but I can post it here for everyone if you want to take a look at it and explore what data is there. In terms of expansion to other regions, thank you for the suggestion. Yes, we do have that in mind and planned for the next biennium. It is a challenging process because I don't know how well aware are people of the process for these data to be collected, but we only contact the ministries of health. And as you know, in many countries, those are not the ones holding the governance for prison health. So that means that we have to contact the Ministry of Health, who then contact another ministry and then nominate a focal point for the data to be reported to us. So for the European region, this is already challenging enough and time consuming, but obviously it would be much more useful if we could reach other regions. So we have this intention, as I mentioned, for the next biennium.
And Filipa, in terms of the way mental health has been incorporated into that data collection, can you speak to that and to how that may perhaps be relevant to the impacts of, say, isolation in detention settings as a response to COVID?
Yes. So, well, currently, just because I mentioned two different sources of data in my presentation, so referring to HIPEDs, this is a snapshot of what happens in a country in a given period. So it's not a dynamic thing. We only collect data once a year, but of course it's important data. So in HIPEDs, what we have that could be useful is data on the service provision. So if there are, for example, psychiatrists available in prisons and how many they are, and then we can compare this information with what we know in terms of workforce per population in the general community. And then we also collect data on the assessment that is made initially when people enter prison. So if there's any mental health specific assessment, and if people are then directed to any special treatment. And then we, of course, have or try to have information on the proportion of people that are diagnosed with a mental health problem. This is not COVID related. This is just an assessment of what happens regardless of COVID. Then the other data set I mentioned, which is COVID related, unfortunately, we do not have that variable in the data set. So it is a minimum data set. And of course, mental health is extremely important, but we focused very much on purely epidemiological variables related to COVID. So number of cases, deaths, transfers to hospitals, and then the testing and the vaccination, not much more than that.
Okay, thank you very much. I might just pose a bit of a challenge, I guess, to all of our panelists here, and that is, you've done a great job in outlining challenges to data collection, data collation, to transparency, to dealing with the different administrative levels of detention settings. So you're all working with globally leading organisations here. What's the next step in terms of how these issues are addressed, in terms of how your organisations work together or work within the opportunities and the constraints that arise? how are your organisations, I guess, collaborating or approaching these in the short term to start dismantling some of these barriers to good global data collection? Might send that one to you first, Peter.
Thanks, Louise. Like I said before, I think one of the key issues here is the willingness of people to share, and the willingness of organizations to be very open about sharing data that then can make or can influence decision making at political level or policy level wherever it is relevant. On a lighter note, we also need to get back to meet in person rather than have Zoom sessions. And I mean that because I think that makes a big difference in actually better understanding where we were coming from. But fundamentally for me, it is really about organizations having to continue to overcome any silos that there might be in the order of identifying the issues that we need to report on and that we need to collect data on, and then make that available to the practitioners who can then make good policy decision, hopefully, and good practice will follow.
Thanks, Peter. Can I invite anyone else to comment on what's your organisation doing as a practical, concrete step to address this?
Okay, I'll go first this time, Filipa. Thanks. Yeah, I think, well, first of all, I want to say thanks for the space for this discussion. I think this is a really good starting point. It's great to have these organizations together, sort of putting our heads together on some of this stuff, learning from each other, and just being aware of what everyone is working on, and how we can all feed into that. Also, it's great to see the number of participants attending the webinar, and hopefully there can be lots of engagement from all of the work that's going on amongst the participants as well, and we can maybe make connections through that. PRI works very closely with prison authorities and with government officials in the countries where we have a presence and where we're running programs. So I think this is always integrated into part of our work around, we really promote implementation of human rights standards, and transparency and openness being a key element of that. So the inclusion of sort of record keeping, data collection is really a vital part of that. So we'll continue doing that sort of streamlined across all of our work. At the global level then, in terms of our sort of policy and advocacy work, we will do a lot of advocacy with the sort of international mechanisms, trying to keep the issue on the agenda, keep a spotlight on prisons, which sort of there was good attention for, and which I think Elena mentioned as well about this sort of hope of, using the silver lining of the pandemic perhaps, or trying to get some good out of a bad situation by this increased attention and focus on places of detention. So trying to sustain that, which has been quite difficult, I think, the longer the pandemic has gone on, because there have been so many priorities and so many issues arising. So I think, working together would be really useful to kind of really try to keep that on the agenda and make sure this is a priority, because it ultimately comes down to resource allocation and priority given to prisons so that they have the capacity to collect this information and to use it to improve responses.
Thanks, Trina. Filipa.
Yes. So I will tell you a little bit of what we have planned for next year. So in the previous HiPads, what we have done was just issue a report with the global data we collected. We have the database, which is open for everyone. And we also have some country profiles that are available in our website, and people can just download it. But we issued these reports, and of course we can monitor how many people download them, but that's it. And we think this is not really creating a visible impact on changing the reality. So for the current data collection, what we have planned is, and we have discussed this with some countries already, and they showed lots of interest, is to have meetings with their respective ministries that are involved in dealing with prison health data, and show their specific gaps. What is the data that they cannot report, and put it in alignment with the general European trend, and then provide specific support to whatever is happening that is keeping them from being able to collect more information. This can sometimes be related simply because they do not collect this data, but it could also be that they do collect it, but they do not have the means in place to make it available on an informatic level. So anytime we need this data, they just need to count sticks, which is, of course, impractical. So we have this planned for mostly for the Eastern Europe part, but of course any country is interested. But my focus on the Eastern Europe is because in general, those are the countries that have more difficulty to provide this data. So I think this probably have an impact in the way that countries can react differently to collecting data. And then we have more work planned, but that's more advocacy, which is an indirect effect. So we have soon a podcast to be launched, which is talking about collaborative ways that exist already in countries where there is collaboration, for example, from NGOs, but also from different ministries involved, and how this can then contribute to having better data in place.
Right, thanks very much, Filipa. And I should mention that we lost Elena. She's been trying to reconnect, but so far unsuccessfully. So it's a shame, but hopefully we might get it back before the end. Lindsay, from the point of view of a researcher in a large research institution, do you have any comment on any thoughts on concrete steps that researchers can take at this stage in order to try to provide some of these, remove some of these barriers that we know of?
I do, and I'd also be curious for Stuart to chime in after I'm done, and seeing as he's our fearless leader at the Justice Health Unit. But I think something that, kind of echoing Felipe and Trina's comments on building relationships, I think researchers can play a really critical role in that, and I think this is an example of that in action. And just furthermore, that I think COVID has clearly revealed that there's a lot of issues, and the justice system was already in crisis prior to this existing crisis or this new crisis, and I think that we really need good evidence and good information, and I think that speaks really loudly to help add to the existing information that we have, but also just ongoing advocacy in this area. I'm curious if Stuart's got any other thoughts, as I'm still quite fresh in the zone. So
just to say, echoing all of our speakers, that coalition building and shared imperatives is what we need to be focusing on. I feel like too often in this area, there's been polarization of debate and different camps with who think they have very different perspectives, but in fact, there's a lot of overlap in their priorities and their imperatives, and an open discussion to identify that as a way of moving forward, I think is really important.
Sorry, I was going to try to squeeze in one more question, but I think we've probably run out of time for it, so apologies for that. But I wonder if, Peter, you might take a look at the chat, and or anyone really, but perhaps particularly Peter, perhaps you might respond to Judith's question about prison health staff. Oh, sorry, probably all panelists. This is relevant to the understanding by prison health staff of the relevance of collecting data. But it's time that I hand back over to Stuart as we do a wrap up. Thanks very much for all the answers.
Thanks, Louise. And as is our tradition with these webinars, I'm just going to give a 1-minute potted summary and then invite each of our panelists to, in probably about 30 seconds or less, add any last observations, thoughts, gems of wisdom, or provocative ideas they want to add. Look, really, really quickly, because we're almost out of time. My kind of summary of all of this, and these are my words, I'm not trying to represent any of our speakers, is We talked about the need for a data-driven response to COVID with broader implications for health responses in custodial settings. And the question is, how do we get there? And so Lindsay started talking about the importance of guidelines, but that's necessary but not sufficient, because without any data or any way of evaluating the implementation of those guidelines, they're just words. Filipa, talking from a WHO perspective, presented for us what's the only regional prison health data collection, which is a really exciting step in the right direction. She's pointed to some really significant issues around data quality and completeness, but Filipa, in the comments that you made in the discussion, you pointed out that WHO is also starting to work with member states to support them to improve the quality of that data collection, which seems really, really important. Trina covered a lot of ground, but I think one of the key points I took from you, Trina, is the real importance of transparency, that this is not just about data for the system. It's not just data for research. It's data for accountability, for transparency, for understanding the extent to which we're respecting the rights and well-being of people who experience incarceration. From an ICRC perspective, Elena, who, by the way, has messaged to say that there was a power outage in her area in Geneva, and she's apologising profusely for being unable. She says she's very disappointed. Elena talked about many things as well, but particularly about the importance of capacity building. And that ties back, I think, Felipe, to what you're talking about, that it's one thing to collate existing data from prison systems around health, but if those data don't exist, or if those data are poor quality, then there's not so much to collate. So in addition to pulling the data together, working with member states, working with prison systems, with health providers in those settings, not only to collect those data, but to help them understand why it's in their interests to collect those data seems to be really important. And then, Peter, at the end, you covered some ground as well. One of the things that really struck me, and I saw people nodding, was about the importance of integration of health and custodial systems, and of integration of health and custodial data systems. That's not just important for COVID, it's important for preparing us for the next pandemic or the next significant health issue that arises. So that's a great point for me to finish. And I would like to finish with our speakers in 30 seconds or less, just sharing any last observations they may have. I'll go in the order in which people presented. So Lindsay, over to you if you've got any last thoughts or observations.
Thank you. I think it's been some really great discussion on what needs to be done, and I'm kind of left thinking about how we can make sure that happens, particularly just considering, regions that don't have as much capacity for data collection or experience a lot of those barriers that Trina touched upon, such as the digital divide and resources, and how can we, work with those countries and those correctional authorities in a way that's effective to try and understand more of those challenges. And I recognize, I think a lot of that work has already been done. So how can we further that, and how can we work together to do that? Yeah, I think that's all I have, but I do think that there's likely a correlation that the regions with the poorest capacity for that data collection and likely are the ones who are not able to share it or not sharing it, or those with possibly the lowest access to basic healthcare, and maybe experiencing the impacts of COVID in potentially more severe ways. So.
Yeah, good points, Lindsay. Thank you. Filipa, over to you. Last words.
Thank you. I think one question that was in fact put on the Q&A is really, really relevant, is if people who are reporting this data are really aware of the importance that it has. And I think that is I'm not sure if it's the most important, but it's one of the most important issues. And I think if we want to change things, we need to show people who are reporting the usefulness of the data they are reporting. So it will be, of course, up to the entities who are collecting this data to ensure the robustness of data and have mechanisms in place to constantly improve the quality. But it will also be up to them to feedback to the units that are reporting and make it transform it into actions that they can then use to improve their practices.
Yeah, thanks, Felipe. Great point. Trina, final comments.
Thanks. Yeah, I guess reflecting on all of the discussion today, I'm sort of conscious that we present this, global overview, and there's such variance between regions and between countries. We sort of have this traditional concept of prisons as maybe shrouded in secrecy or very closed institutions, which we mentioned a few times today. And this is really changing, thankfully, in many places with external monitoring and access to prisons for service providers and civil society becoming the norm. So this, I think, change and this shift really improves the ability to sort of reach our goals that we're talking about, but it's not the case everywhere. And the pandemic has just been the starkest reminder of how important all of this quality data on prison health is to not only respond in the time of crisis, but to recover and inform our future responses. So I think I just also want to bear in mind that like every figure and data we talk about are real people and real needs. And that's why we're doing all of this work and why it's so important. So I'm thankful for the discussion today and the space to learn from each other and look forward to continuing to collaborate on it.
Thanks very much, Trina. And Peter, final words from you.
Yeah, thank you. And I certainly endorse the comments made by the other speakers. I think it's about continuation of collaboration, sharing with a view to integrate as much as possible, very proactively dealing with professional boundaries that all too often are used as an excuse not to share. So I don't have any issues with professional boundaries, but they need to be managed responsibly. And most importantly, build capacity. And when I talk about building capacity, I'm very cognizant, obviously, of the great differences across the globe when it comes to where systems are at. But that's not to say that we can't do something, that we don't have opportunity to do something anywhere we go. And now this is a great start. And I certainly thank University of Melbourne and the Justice Health group for facilitating this dialogue. And I very much hope that this, as much as very other contributions in the COVID dialogue and space, will continue to improve systems as we go forward.
Thanks very much, Peter. And we are at time, but I do want to again thank our audience very much for joining us and for adding to the questions. And I really want to thank all of our speakers very much for taking the time to share their expertise and wisdom with us, including Elena Leclerc, who unfortunately had a power outage. But thank you very much, all of you. I wish you all the best. Stay safe, and we'll look forward to seeing you some point down the track.